Aesthetic crown lengthening, Part 2, simple crown lengthening. There are three types of aesthetic crown lengthening. This is the first. Simple crown lengthening is removal of the facial unattached gingiva. And I want to emphasize the word unattached, and you'll see why that becomes so very important as we proceed with this video. The second type, compound crown lengthening, removal of facial gingiva and facial bone, is typically what we will do in most cases. And third, complex crown lengthening is removal of facial gingiva, facial bone, and interdental bone. Now this is a case that was sent, and the chief complaint is a patient felt that this canine looked like a fang. And that tooth is about 11 millimeters long, exactly what it should be, but the problem is the other teeth are not as long as they should be, and because this is a post-orthodontic patient where the probing depths are greater than we see in the adult patient, and there's an abundance of unattached gingiva, we can consider doing simple crown lengthening when we have a normal to thin biotype, and I think you would call this a normal biotype. As we look at this lateral incisor, the length of that tooth is 7 millimeters long, and it should be 9 millimeters long. Whereas on the central incisor, the distal of that tooth should be 11 millimeters long, and it's 9. Here we're using a caliper to make the bleeding points. Ideally, on the distal facial of that central incisor, the tissue level should be at 11 millimeters, and on the mesial it should be 10.5, meaning that the emergence profile will be better if the tissue level is about a 0.5 millimeter higher on the distal than on the mesial. And you can see this is ideally what we would like to have. But as we look here, we see the free gingival groove, and that is right on the free gingival groove. So what we want to do is not go 11 millimeters on this tooth. If we're going to do simple crown lengthening, we'll only go 10.5 to be sure that the incision is made in unattached gingiva, leaving about a 0.5 millimeter of sulcus depth. And if you leave a little sulcus depth on there, you will not get the rebound that we're going to talk about later. The caliper that we mentioned, you can see here, we twist, and if we look at the end, we can see that we want to go 10.5 millimeters, so we simply crank that out to the distance that we want, place one point on the incisal edge, and the other sharpened point is used to make a bleeding point, as we are doing here. Here we're making the bleeding points. This is probably the most important slide that I'm going to show you, and that is showing how much tissue can be removed. If you will note here, we would like to remove about 2 millimeters of tissue. And if we look here, you can see where the bleeding point is, 2 millimeters, but look where the probe is. It probes 2.5. And this points out the importance of not severing the epithelial attachment, leaving that intact, leaving a 0.5 millimeter of sulcus depth, and if you have a normal to thin biotype, that should be able to be maintained indefinitely. So this is where we started, and here's where we have done the radiosurgery, and you will note that there is no bleeding. And on the central, on the right, which is the patient's left, we have a more ideal architecture because the tissue is higher on the distal facial than it is on the mesial facial. Notice on the pre-op that, as I mentioned earlier, the canine looks like a fang, and now we see after treatment the canine does not look like a fang, and yet that was the only tooth that we did not do aesthetic crown lengthening on. So this is where we started, and this is the way it looks 3 weeks later, and notice how thin the papilla are. We have a thinner biotype, and that can be maintained, and we have a painless type of surgery similar to what we would have with a soft tissue laser. Now, look at this case. As we look here, specifically, you can see the free gingival groove. So what we did was go in there and use the radiosurgery to make our incision. You can see the charred tissue. Then we take a curette and go ahead and remove that. And here we are removed with a curette. And then we take a pointed tip and just reshape the papilla so that they are nice and thin. Now let's look at a 3-week post-op. You'll see that we do still have a free gingival groove. We've got about a 0.5 millimeter of unattached gingiva, which is the sulcus. We have a thin biotype, and there's no reason that this should rebound, but look at the aesthetic impact on this particular case. This is one of my favorite cases. This lady was referred in from the Church Health Center, which is a clinic for the working poor. And when they need specialty care, in this case periodontal care, they're referred to a specialist, and we agree to do whatever treatment can be accomplished in an hour for the $25. And in looking at this, she had a trauma to this area many, many years ago, and almost all of that keratinized tissue is unattached. Yes, it's a thick biotype. So what we did, we went in there and used the radiosurgery to not only remove that, but notice the bevel we placed in an attempt to get a thinner biotype. But we did match it up with the other central incisor, and we now have two central incisors that are 9 millimeters long. And now we have gingival symmetry, which is one of the prerequisites for an aesthetic outcome. This is where we started. This is the way she looked 3 weeks later when she came back. And in looking at this slide, unfortunately, in the papilla area, we still have a thick biotype. And I wish I had thought to go in there and festoon that area and thin the area, for I think we're going to get some level of rebound. To view additional information, including technical information and the application of radiosurgery, please click on the screen annotations or the link to the video description. Enjoy using this procedure.